welcome everyone. My name's Andrea Miriam with PMD Alliance. So glad to have you tuning in for this lunch or afternoon session to learn with Dr. Falkner. I will introduce him briefly and then turn things over. Dr. Falkner is a movement disorder specialist in Northern Virginia. I think he has the most important part. He's a Golden Doodle owner.
A Bernedoodle, and he's nuts. That's what we got, and it's amazing.
And really excited to have him. He's great at speaking to patients, translating some of this high science into really, understandable, easy to digest and understand terms. So very excited to have you here today, Dr. Falkner. And if you want to add in any more fun facts before you share your slides, I'll turn it over to you.
Ooh, fun facts. I mean, that's a big one. I think my big fun fact is that I had a hip surgery last Friday, so I am still laid out where I've been for the past week. I know it's been fun. It wasn't a big thing. It was an arthroscopic thing. I'm fine. But I'm still in my like recovery don't walk window. And I can tell you when you go from like going, I don't know if anybody on this call is like a real like high energy kind of person like I am. Like being told you can't move for a week, it's like maddening. So I am so excited to be here today to pretend like I am not just lounging around doing nothing as I've been doing for a week. So that's my fun fact. But I appreciate everybody giving us the time today. I appreciate PMD Alliance for putting this together. And I love that this is the Parkinson's and Movement Alliance, yet we are giving a talk about essential tremor. And essential tremor is important. It's incredibly important because, as you'll see, this is a condition that is incredibly common. It's something we see all the time in clinic. It's something that outnumbers Parkinson's 10 to 1. And people with Parkinson's can also have essential tremor. So it's kind of a fun one to go through because it's a little different. And it just builds our knowledge base of all the things we treat and all the things we do. So, if it's okay with everybody, I'll pull up this slide deck we're going to talk through, and then we can get to the business of spreading some knowledge. Let me see here. Okay, I got to click all the buttons here, guys. Give me a second. Cross your Zoom fingertips. Let's see if this will work. Okay, come on, Zoom. I think by now it would be faster, but it's not. Actually, you know what, guys? Hold on. I'm gonna try something different. I meant to hit a different button. I'm gonna try the magical zoom thing. Has anybody seen this where I like float in the bottom? See if my
Oh,
see if my
I have
computer
seen
can
that.
do it. I know we're gonna try it. Hey, tell me if this works, by the way. Am I floating in the bottom of the screen?
Yes, you are.
I know it's a little weird, but I'll take it, right? So this is this is new Zoom where I float in the bottom, but it makes me feel a little detached, like I'm floating in space, but I'll take it. So what we're going to talk about today, everybody, is living your best life with DBS. This is a sponsored talk by Abbott, one of the companies that makes DBS. Thank you, Abbott, for bringing us together too. But through this, I always enjoy speaking on essential tremor for all those reasons we just spoke about. The main one being that this is an incredibly common tremor condition that we actually, as movement docs, don't treat a lot. And I wish we did. Essential tremor is fundamentally different from Parkinson's disease. It is actually the most common movement disorder that exists. And yet, if you look at our clinic, we are, as movement docs, usually about 60 to 80% Parkinson's, 20% everything else, and essential tremor only usually makes up about 5% of the people we see. So, with that in mind, you're probably thinking, how could that be? Well, that's what we're going to talk about today. We're going to talk through essential tremor. What is it? How does it look like? So that if you have a friend or a family member who has it, you can give them a little push to try to treat it. We're going to talk about how we treat it. And then again, just like we do with Parkinson's, we are going to talk about deep brain stimulation because our two big indicators for DBS are essential tremor and Parkinson's. In fact, did you know, back to that whole factoid quiz bowl thing, did you know that deep brain stimulation was first approved for essential tremor? Yes, it was essential tremor in 1997. And then DBS was approved for Parkinson's in 2002. So this is an important part of what we do, and I'm happy to share it with you today. So let's jump in. There we go. Before we start though, and this is such a big part of what we do as movement docs, it's about us treating you. It's about you as the patient, making you better and being with you on that journey. So I always love starting talks with a video of a patient who can tell us what they were going through. This is Keith. He's a gentleman who has essential tremor. Let's hear what he has to say. See if it'll work while I float in the corner here.
My name's Keith. I have essential tremors. I work in orthopedics. Before my tremor started, I used to go into the operating room, help with surgical procedures, and unfortunately, I'm not able to do that anymore. Well, the first time I started noticing the symptoms, I was a sophomore in college, played a lot of basketball. I was really active. I'd go out and do a lot of running. Once the tremors started progressing, you could just see everything just starting to decline a little bit. I decided to get the procedure done because you can't do anything. You can't eat, you can't write. Every time you pick up a glass of water, it's all over the floor. Or you try feeding yourself and you got food all over the table. You kind of start isolating. Don't go out to dinner, because you're just paranoid you're going to make a fool out of yourself.
So these were all very common things that we hear about essential tremor. Essential tremor is a tremor that happens with activity, not necessarily at rest. So for everybody on this call, we tend to think about Parkinson's as being this resting tremor, this tremor that happens when you're relaxed, watching TV, there it goes. And with Parkinson's, you can get a tremor with doing things, with holding items. But essential tremor is kind of the opposite tremor of Parkinson's disease. If the majority of Parkinson's tremor is at rest, then the majority of essential tremor is with activity. And we're going to talk about what that means as we go, because the common symptoms we hear, just like Keith said, and think about it, it makes sense. If you are shaking when you're doing things, then anything that requires stability or precision becomes really hard. Everything from using your phone, putting on makeup, even brushing your teeth, eating, drinking, cups go everywhere, handwriting. Tremor with activity is a disabling thing for people living with it. So, we're going to talk about essential tremor, what it is, how we diagnose it, how we treat it, and then we're going to go into why deep brain stimulation works because it is a mainstay of therapy and has been for almost 30 years for how we make tremor better. It's kind of fun. So, as with all conditions, to me, it is always fascinating to begin with, well, where does this come from? Why do people shake? Well, with essential tremor, it's important to realize that the tremor actually comes from the very back part of the brain. Your brain is this big squash up in your head, and there's this little organ at the back of the brain called the cerebellum. People have heard of the cerebellum? Yes? Well, your cerebellum works in a very important way for movement by controlling and balancing movement. Think about that. So if I'm going to reach for something and I'm going to grab it, or I'm going to have a cup and I'm going to bring it to my mouth, there has to be a part of the brain that coordinates that movement to make it nice, fluid, and even, right? If I hold my hand out, the muscles on top need to be balanced with the muscles on the bottom to keep it steady. If I'm holding a mug, the muscles on the top and bottom need to hold it steady against each other to keep it from moving, right? The thing that coordinates that movement, that stability, that fluidity of movement, the targeting system of the brain is the cerebellum. And with essential tremor, the cerebellum is not working as it should. Essential tremor is a genetic condition. It's baked into one's genes. It is present from birth. And what happens is that with essential tremor, the cerebellum that's normally in phase to balance things is a little bit out of phase. And by being out of phase, the cerebellum can't balance the coordination of movement. So when I go to reach for you guys Instead of being a nice fluid move, the muscles pull against each other because the sinking, the balancing component is gone, and you shake. When I go to eat and I have that fork and I'm bringing it to my mouth, the system of the brain that coordinates the fluidity of the movement is out of phase, and so that movement shakes. That is essential tremor. And knowing that it's a cerebellar problem is incredibly important because of the symptoms we get. It's a tremor with activity when you're trying to do things, and because it can also impact balance and gait. Because if your arms aren't being coordinated, walking is a very coordinated thing too, and it's very, very common in essential tremor to have balance issues as well. It's also, I said it earlier, and I mean it, the most common cause of tremor out there. In fact, it is 10 times more common than Parkinson's. Right now, we are treating 1 million people in the US with Parkinson's disease. There are, by diagnosis, 10 million people in the US living every day with essential tremor. This movement disorder represents 1% of the population of the world. It is the most common one. And so it's called essential tremor, in case you were ever curious, because it impacts the essential functions of everyday living. It impacts eating, drinking, dressing, writing. The essential activities are affected, so we call it essential tremor. We used to call it by a different name. It used to be called benign familial tremors. You guys might have heard benign familial tremors. That is now essential tremor. It is the same thing. The reason why we changed the name is number one, for many people, it's not very benign, so that's not fair. Though by benign, we meant that it usually doesn't turn into something else, which is good. In the familial point, not everybody with essential tremor has family history. Now, the majority of people, this data says 50%. There is studies that say up to 60% of people with essential tremor do have an identified family history. This is a problem in the genetics where the cerebellum is built out of phase, and that is, for the most part, an inheritable problem. Most of the time, if we diagnose someone with essential tremor, they say, yeah, my sister has it, my mom had it, my aunt had it. They find some way to have an inheritance pattern, though it doesn't have to be that way. So we changed the name because it's not always familial. It's not very benign. We changed the name to essential tremor to better encapsulate what it impacts, which are the essential activities of daily living. So what does it look like? Well, as I've said, it is a problem with targeting. It's a problem with movement. An essential tremor does not happen at rest. If someone is sitting there relaxed, watching the latest season of White Lotus, unless they're getting really worked up because it is a crazy show, they will sit there and not shake, right? This tremor happens when holding the arms up against gravity because that involves balance of muscles, and it also involves while doing tasks. Again, eating, trying to eat with a fork and knife, drinking out of a cup, handwriting can be affected, but any task that's a voluntary movement can shake. I have patients who try to do a screwdriver and it becomes irritating because they can't get it on the screw. People who sew have a real hard time with sewing because it causes shaking. And it can also cause a shaking in the head, and it can cause a shaking in the voice, where the voice can quaver and shake as well. And it's important to remember a couple other things. Number one, this does change. You know, people, we like to call it essential. We didn't like to call it benign because it does change. Everything changes. The most common age for people to be diagnosed with essential tremor is after the age of 40, but there are kind of two humps of when it presents in people's lives. We have this whole group of people, like you heard the Kevin say, that experience their tremors coming on when they're teens or in their 20s or their 30s. Then there's a whole group that gets these tremors later in life, usually after age 50, but it's all essential tremor. Again, we talked about the genetic risk factors, and it is actually most common among people older than 65, which is why when we're talking about Parkinson's disease diagnoses, when someone comes in for evaluation of tremor, the two main considerations we have are, is this essential tremor or is this Parkinson's? And it's very common for folks to be misdiagnosed as one or the other. Interesting fact about essential tremor, and this goes to the last point on the screen. Often, essential tremor is incredibly effectively responsive to alcohol. Yeah, having a good stiff drink. And the reason why makes sense if you think about it. This is a problem with the cerebellum coordinating movement. Alcohol potently suppresses the cerebellum, right? All of those drunk tests that we think about with police officers, the touch your nose, the follow my finger, the walk in a straight line, those are all testing the cerebellum. And the reason why is because if you have too much alcohol, if you're intoxicated, your cerebellum is suppressed. And so your ability to tandem gait, to touch your nose, your eyes, movement becomes altered because your cerebellum is suppressed. Well, that's bad if you're driving. Don't drive under the influence. But if you have essential tremor, a lot of patients have discovered that if they have a cocktail, their tremor actually gets surprisingly better. The reason why, again, we have an outflow problem of the cerebellum. Have an alcohol drink, suppresses the cerebellum, tremor gets better. Now, this works at cocktail parties, but it's not a great way to treat a medical problem. In fact, we often see issues with alcohol dependence in essential tremor patients when they discover that connection because they start to self medicate with alcohol because it's so effective in helping their tremor, but not a good thing over time. So, what's the distribution? Well, essential tremor typically and most classically involves the upper extremities. It's in the hands, doing things with the hands. The tremor can be severe, it can be mild, it can be easy, middle of the road. We have some tools we use, but there are tremors with essential tremor that happen in the legs. There are tremors that happen in the voice, in the head. Because it's a brain problem, the tremors can affect any part of the body, but it's mainly noted in the hands when you're trying to do things. So here's a couple examples of people with essential tremor. We have the person on the far left who is now trying to write on a piece of paper. You can see it is a very shaky handwriting, and their hand is shaking as they're having to do it. He is trying to write, "Today is a sunny day." Very, very shaky. We have this gentleman who's trying to drink out of his coffee mug. God bless him. I love coffee. Um, you can tell he can't really do it. He has to use his second hand to anchor the shaking of the cup. This is a very classic tremor in essential tremor, and you can imagine if he had a full cup of coffee, that would be a big mess. And then you have this lovely lady who, God bless her, she's a Patriots fan. Seen better days in a fan base, but this year might be the year they come back. You can see she's really shaking when she holds that mug.
You can steady it with two hands, but not with one. I am left-handed, so my left hand is more dramatic than my right.
You can actually hear a little vocal tremor with her too. Her voice is shaking a little bit.
Right, but it's very dramatic.
And for her, for a lot of people with essential tremor, carrying something heavier can actually bring out the tremor a little more. So how do we treat essential tremor? Well, there are really just two good medicines that we use to try to help. Here's the deal. There are these two medicines that we're going to talk about in a minute, but anything outside of that has what we call kind of anecdotal status. And that is that any medicines or oral therapies outside of these two medicines that we'll talk about, they haven't really been confirmed to be meaningfully effective by a good study. They tend to fall into that category of, oh yeah, I had a patient once where I gave them Keppra and it helped, right? But outside of these two medicines, we don't have a lot of confidence that other medicines can help significantly, okay? And the other challenge is, one of the big limitations to treating essential tremor is that we have not had a medication indicated specifically for essential tremor ever. The two medicines we used were repurposed. And we haven't had any new therapies to treat essential tremor in the past 20 or 30 years. We just had a number of studies that were trying to find new agents to help. And unfortunately, none of them actually struck gold and gave us a medicine that could benefit essential tremor. Really disappointing. So what are those two medicines? Well, the two medicines that we use are number one, the medicine propranolol, and number two, the medicine primidone. So propranolol is actually the one that we start with. Propranolol is a medicine that is in a category of medicines called beta blockers. It blocks beta receptors because on your muscles peripherally outside of your brain, the receptor that drives tremor is a beta receptor, lo and behold. So if you take propranolol, it blocks the receptors on the muscle, causing the shaking, and calms it down. Propranolol is a very effective treatment for essential tremor. If we look at the data, it tells us that we should expect a response in patients about 80% of the time. So 80% of the time we start propranolol, a patient says, I notice it changed, right? And the risk of side effect of propranolol is actually very low. Now, there are two types of propranolol. There's an immediate release tablet, which is in little bitty doses that you have to take probably 3 times a day for it to work. And then there's an extended release that we really like in the movement community. That's a capsule that you take once a day and it lasts for 24 hours. This is a medicine, again, that we use as first line because it goes to where the muscle is shaking and calms it down. Now, propranolol, by being a beta blocker, the big risk is that it can lower heart rate. So if you're a person who your heart rate is running in the 80s and 90s or even 70s or 60s, should be fine. But if you're that one of those people, and I always say that's amazing, who their resting heart rate is in the low 50s, probably not a good medicine to try because we don't want to suppress heart rate any lower, right? So propranolol is step one. Step two is this medicine called primidone. Now, primidone has been around for a long time. It is an old anti-seizure medicine, and primidone works on essential tremor by working in the brain in the cerebellum. So what happens with primidone is when you take it, the initial medicine primidone works on tremor. It helps suppress cerebellar activity, and it helps on tremor. And then primidone breaks down into a barbiturate. So a medicine that works on the cerebellum to suppress it for a long period of time. In fact, the effects of primidone on tremor tend to be about 2 to 3 days per dose. So remember that. Now, because primidone works in the brain, because it breaks down into a barbiturate, which is fine in the right setting and if you tolerate it, the main side effect of primidone is sleepiness. And so what we see in the data is that about half the time people say primidone helped. The other half the time, they don't tolerate it because of a side effect. Additionally, primidone has a lot of drug interactions. So we have to be very careful when we add primidone to not muck something else up. The most common being an interaction with Eliquis, which is a very common blood thinner. So we have propranolol, we have primidone, and we actually, because they work so differently, what we tend to do clinically is try one, add the other, and then we can actually try giving them together. There is a synergistic effect of taking propranolol and primidone because they both work on different systems that are affecting the tremor. Now you can see on your screen there are other medications, including benzodiazepines and gabapentin and topiramate. Mixed bag on whether I can tell you they genuinely work. We tend to not stray into that category unless we really need to. But here's the challenge. If we look at the people who say the medicine helps, it's only a fraction of the people who live with essential tremor. Now, it's more than most, it's more than 50%, but it leaves a big swath of patients with essential tremor who either the medication didn't help or they had some sort of interaction or side effect and they couldn't take it. So if that's the case, then the question becomes, well, what do we do? Here you have a tremor that affects the activities of daily living. You have a tremor that impacts your ability to do things. Well, if the medicines don't cut it, the next step is to genuinely ask the question, well, how much does the tremor bother you? How much does it affect the things you do every day? And a very important question, how much would your day and your activities be better if we could make the tremor better? And if the answer is yes, the tremor bugs me and I want to try to make it better, it's impacting the things that I do, and thinking of having less or no tremor is awesome, then we move to the conversation about surgical interventions. Remember, we know it's from the cerebellum, and we can track in the brain where that inappropriate signal from the cerebellum goes to give symptoms. And in fact, a place that we can get to, a place that we've identified, is not in the cerebellum, but one step further down that communication pathway in an area of the brain called the thalamus. So your thalamus is like the switchboard operator of the brain. It's a very common pass-through area. And we know the place in the thalamus where that inappropriate signal of essential tremor runs. So in terms of surgical therapies, we have really two approaches. Number one, injure or create a burn a hole in that pathway in the thalamus, block it, and hope it doesn't work around it. Or number two, put a lead into that brain, a pacemaker, DBS, where we can then deliver energy into an energy pathway that's firing incorrectly to shut it off. And so that leaves us with lesioning, which is ultrasound lesioning, ultrasound, focused ultrasound, or gamma knife, or deep brain stimulation. And so we'll talk about that as we go too. So, yeah, I said this before. This is just the full slide. It's not really that there's an interaction with beta blockers, propranolol. This is more primidone can interact with these agents. A lot of times, the other medicines you're on can impact our ability to use primidone. So, another thing to realize, one of the most common misdiagnoses out there is essential tremor. That might be why the numbers are so high, right? If you go see a general practice doctor and you have tremor, you're probably going to walk away with a diagnosis of essential tremor. If you have tremor, please go see a movement doc or at least a neurologist and let them really add confidence to the diagnosis of essential tremor. Essential tremor, just for a lot of people, means you have tremor, but there are many causes of tremor that aren't essential tremor. So how do we diagnose essential tremor to that point? Well, unlike Parkinson's disease, there's not really a medical test or a genetic test we can do. So really what we do is we look at you, we look at the tremor, we see how it changes when we do certain things, and then we use our clinical acumen to determine a diagnosis. That's part of the reason why the clinical diagnosis can change, because if something changes, we might say, ooh, we thought it was essential tremor, but in reality, it is this. So just follow with your doc, talk to us. It's important to get it right. So here's a comparator between Parkinson's disease and essential tremor, two of the most common tremor conditions we have. You can see tremor location. Parkinson's tends to mainly be in the hands, arms, and legs, while essential tremor can be everywhere. Parkinson's, because it's a brain disorder of dopamine, affects everything, while essential tremor is really just tremor. The duration of essential tremor is much longer usually than Parkinson's, with a family history, with significant alcohol responsivity, and the rest of the things we spoke about. Okay, so how do we tell our patients to manage essential tremor? Well, number one, we have to make sure the diagnosis is correct. And number two, we have to try the medications to see if they can help. And if the tremor continues to be a bother, or if the medications were either intolerable or didn't help, then I promise you the question I ask is, well, how much is your tremor affecting the things you do every day? The things that I take for granted. How much does it affect drinking your coffee in the morning? How much does it affect tying your shoes? How much does it affect the social things you do? And then just for a moment, play the game of how would those things change if we were to able to make the tremor better. And if that idea of better is compelling, then we need to talk about another step, which would be a surgical therapy to try to intervene. So the most common surgical intervention we do is deep brain stimulation. And the reasons why we'll talk about today, but I do want to remind everyone, like I said before, that the original approval for DBS in 1997, which according to my kids was like a millennia ago. In fact, my kids called it the late 1900s, which made it sound incredibly long ago. But the first approval for DBS in 1997 was for essential tremor. So let me show you how deep brain stimulation impacts tremor, okay? Here's what you need to know, and this is true of Parkinson's just like essential tremor. DBS works like a pacemaker in the brain. It is a device that delivers energy to an inappropriate pathway, because remember, your brain is an energy organ that signals with electricity. DBS delivers energy into an abnormal pathway to block it, to turn down the symptoms. And because we know where the inappropriate signal of essential tremor travels, because we can get there with the DBS, and because we can deliver energy as therapy, we can watch the essential tremor get better. So this is the gentleman from earlier. He was the guy with the coffee mug who was really trying not to spill it all over his lovely white shirt. Let's see what deep brain stimulation did to help his tremor here. I'm just going to let it play. Let's see here. Okay, this is him with the DBS off. We saw this video earlier. You see he's got pretty significant tremor, not at rest, but when he's holding something and trying to move it, a kinetic tremor. I mean, this is the kind of, I need to fill up my cup just a little bit every time, otherwise it goes all over your nice white shirt. And then this gentleman got deep brain stimulation. It was adjusted and programmed, and now he's going to turn it back on. And you can see it's off right now. The red bar means it's off. This is his iPhone. He's adjusting it. Now he's going to turn it on. Okay, there it goes. It's turning on. Let's watch his coffee mug. And the signal of DBS has blocked his tremor. And now he can drink. It is one of the greatest party tricks as well, because you can show people how quickly it works at your family gatherings, right? That's not really a joke, but it's also a half joke. But that is a very common response to a well-programmed DBS. So essential tremor occurs because of abnormal signals. DBS can go to that circuitry and block it, making the tremor better. The nice part about DBS2, which is different than the lesioning procedures like ultrasound, which creates a hole, is that we can adjust or program differently how the DBS runs. In fact, just like that gentleman, if your doc allows it, we can give you control to go up or down on the settings to help the tremor. Because remember, like we said earlier, these things change. With age, with life, tremor changes. We like DBS because it's an option that allows us to adjust our therapy as time goes on and as things change. Okay, so how does it help? So this was a study from a number of years ago on the Abbott system. And if we look at folks at 10 years or more with DBS, 10 years or more, we've received we on average see an 80% reduction in tremor. That was at a year, but then that sustained and got good tremor control for 10 years. So the numbers we tell our patients is that with DBS, we should expect about 80% less tremor. Might not mean gone, but it means better. Or for some people, it can actually make the tremor go away. Now, it doesn't mean the tremor's gone. It just means that we're using a therapy, the electrical therapy, the DBS, to effectively block it. So 80% better for most. Some people, resolution, and that lasts for a long, long time. That's why we like it. Okay, so what about you? You all out there, are your friends with DBS, or with the essential tremor, sorry, are you thinking of DBS? So we talk about deep brain stimulation as an option when the medications either don't work, you can't tolerate them, and the tremor is impacting the things you do every day. And again, the idea of it being better would help. Now, you aren't a good candidate for DBS if you have significant cognitive impairment. We don't like to do brain surgery when there's dementia. And you have to be a good candidate for surgery. This is a stimulator. This is a pacemaker-like device that we put in the brain. So you got to be a good candidate for that. So if we look at DBS a little deeper in terms of essential tremor, and we see how people do after the therapy has been programmed and people get better, well, lo and behold, Abbott DBS gets people back to their daily activities. Their ability to write, to drink, to work with their hands are much improved. There's a direct connection to improved physical and social activity as well as mental health. And again, 80% better tremor, if not resolution, is pretty darn good. And so if we look, doctors prefer directional DBS. So directional DBS, Abbott DBS, is a system that we've all used for many years now. And if we're looking at directionality, which is the modern way we deliver DBS therapy, it is preferred by doctors, by their patients. 9 out of 10 people are very satisfied with the effects of their stimulation. And DBS, if you ask people after, would you recommend deep brain stimulation for essential tremor patients? 96% of the time we hear a yes, which is pretty cool. Okay, so what goes into getting DBS? Well, like I said, it's a pacemaker-like device which lives under the collarbone. And then there are wires that are all on the inside that go up to the top of the brain, and then leads go to that deep part of the brain where this pathway is and allows us to deliver therapy. It is all in the inside, I promise. Ooh, this was the lady with the Patriots mug, which, again, I think you're going to have a better season this year. Let's see what happened when her DBS was turned on. Remember, let's see here. I'm going to let it play. She was the one who she was holding anything and was shaking.
Candy Bowie, and I have an essential tremor, which I have an Abbott Deep Brain Stimulator. This is my programmer. I turn it off every night and turn it back on in the morning. Right now I have it turned off for this experiment or video. I'm gonna try to.
That's a
This is
serious
me
coffee
trying to
mug.
drink coffee with it turned off. It's
Like a
just
3-cup
water
coffee
in there
mug.
now.
If I asked her how much coffee she drank a day, she'd say 1
That's
cup.
my coffee cup.
Really be 3 cups.
I started feeling the effects of the tremor when I was about 30, and it just started in my index fingers and worked its way to both hands, my throat, and my feet. This is the cup I drink out of all day long. Maybe.
Good tremor.
I can steady it with 2 hands, but not with one. I am left-handed, so my left hand is more dramatic than my right. There's a little tremor in the right, but it's very dramatic in the left, as you can see.
A lot of tremor. Okay, let's see what happens with Candy, Patriots fan, when they get a better coach and we turn on
Red says that
DBS.
it's off.
I don't think it was the
You
coach's
turn
fault. I think it was the
on
system's
now.
fault. Actually, like Mayo, he was awesome.
My boots up in 8 seconds.
Okay, her
Although
DBS
this
is turning on.
something that can be adjusted.
And now you've learned that I really like Coach Mayo. I hope he lands on another team.
Length of time.
Okay, let's see what her tremor looks like.
Okay, so it's turned back on now. You can see how easy that
Now,
was.
if you notice, her voice actually improved too. Because she had a vocal tremor before.
Just get a hold of this.
Let's see how her Patriots mug is doing.
Dramatic change. I can
Much better,
actually
right?
Pick it up with one hand
And you can see she still has a little tremor there.
and not impale myself with a straw.
That's like an 80-90%, right?
Shakes a little bit, but nothing
Much better.
compared to what it was.
Here comes the giant queen mug.
Coffee cup.
That thing looks heavy. I think it's made of stainless steel. It might have been
Mouth
cast iron.
down.
That's a huge mug. So, Candy got better. Now, what goes into getting a DBS? Well, there are 2 surgeries that go into getting DBS. Yes, it is surgery. It is a neurosurgery. It is a brain surgery. This is a big one-time surgery to give you a tool that we can use into the future to help. I don't minimize it. This is an important part to consider in all of it. So the first surgery is the important one. This is where we are putting the leads in the brain to get to the part where we can influence the tremor. This involves, for most people, staying in the hospital for one night just so we can keep an eye on you. So how it works, we do a whole lot of planning and imaging ahead of time. And then we use, a lot of places do, a certain kind of frame so that it guides the neurosurgeon to put the lead in the right spot. We actually, in the operating room, will confirm that it's in the right spot by turning it on and watching the tremor stop or get better. And then the doc closes you up, puts you rest in the hospital, and you go home and recover. And then there's a second surgery that usually happens a week or 2 later, and this one's outpatient. They just knock you out, and the whole purpose of the second one is to connect the lead in the brain and put the generator under the collarbone like a pacemaker. So this one is pretty quick. All they do are hooking everything up. And then you go home and you rest, and you meet up with your movement doc or whoever's going to turn it on about 3 to 5 weeks after your procedure. We got to let everything heal up. And at that first visit, you come into clinic and we turn on the device and we try to figure out where is the best spot to deliver stimulation to make your tremor the best. And the cool part about Neurosphere, the thing that Abbott offers, is that they actually have a virtual clinic option where we can connect over telehealth and adjust your programmer remotely to keep you from having to come into clinic. Now, then what happens from that point? Well, what happens is you follow us at a normal interval, and at our visits, we do our usual thing. We talk about life, we talk about your tremor, we try to hopefully get you down or off of your medicine, and we adjust the DBS to optimize how it's controlling your tremor. Nice part too is that it tends to be very well covered. It is considered standard of care in the treatment of essential tremor. So most public and private health insurance plans, including Medicare, cover it extremely well. Your team will, of course, go through all of that before any surgery. I will tell you, I've been working with deep brain stimulation for about 10 years now. Crazy to think. We have not, knock on wood, had a person who the cost or coverage was an impediment to getting the therapy. So there are potential side effects. You got to talk to your doctors. That's what we're here for. Talk to your neurosurgeon about the risks of surgery. It is surgery. And then in our world, with the programming itself, putting energy into that part of the brain can cause side effects. Now, most of our side effects can be controlled by adjusting how we're delivering the therapy. But stimulation going to the wrong spot can cause muscle contractions, tingling, it can affect speech, and it can cause some balance issues. But we tend to work through these or around these by adjusting how we deliver the stimulation. Okay, let's see. I remember the guy from the beginning who couldn't write. Look, there, it gave away the secret, but let's see how he did. Okay, let's see here. This is the gentleman who we were trying to get him to write. Today is a sunny day. Today, you can sort of read it, but man, he has a shaky handwriting. That is classic for essential tremor. And now if we turn on his DBS, because remember, we are blocking the pathway that causes shaking. This is how the same guy writes, today is a sunny day. Ooh, we even did it in script. I mean, I don't know if my script game is that good anymore. Much better. So here are the different components of the system. Oop, I didn't mean to go that fast. We have the little cap that goes in the skull to hold it in place. The generator is a little bitty thing that goes under the collarbone. There's a connector. There's the programmer itself. And by the way, with Abbott, you can load it onto your own iPhone. And then the leads themselves that go into the brain. Now, none of this is to scale. I think we need an asterisk that says that because the leads themselves are actually really tiny, and so is the cap. And an iPhone is much bigger than that, but none of it is to scale. So here's a video about directionality. Again, if this lead is in the brain and we're trying to put energy into a pathway, directional DBS, which is to us now the standard, allows us to move that energy side to side to really target the best place to stimulate. Super cool stuff. And in terms of directionality, there was a big clinical study that was completed that showed that 9 out of 10 people with DBS would benefit from Abbott's directional DBS compared to conventional, and that there are much fewer complications with Infinity DBS directional systems versus non-directional systems. And remember, too, that with Abbott, they are the only company out of the three that is approved for bilateral DBS for essential tremor. If you've been on any of the educational events with the other companies, you know we make a very important point of saying it's indicated for unilateral or one-sided implant. Well, Abbott is the only company that has approval to do both sides, which is the most common way that we implant for essential tremor. And yes, if you look at directional DBS with Abbott, 7 out of 8 patients prefer it. 86% had tremor scores improved at 6 months, and the window of stimulation is bigger 91% of the time. I mentioned this earlier. The Neurosphere Digital Care Kit that comes with Abbott is really nice. It is we have 2 different systems. We have one that is a primary cell battery where you don't have to worry about it. Don't have to recharge it. It just runs, and when it starts running low, we change it out. But we also now have a rechargeable system that extends the use of that battery for 10 plus years, but it requires charging it up, which is not that big of a deal. With Abbott, you can get the programmer, the thing that you use to interact with your device on your own smartphone, an iPhone. And with that, we get MRI conditional approval, so you can get MRIs, and we have the ability to do telehealth or remote care through your device. Okay, let me show you that. I think there's a video here. Yep. So okay, come on. There we go. That's what it looks like, your patient programmer, where you can turn the device on and off. You can change the settings on either side as you want. There is a nice sleep timer, so you can go to bed and have it turn off 30 minutes or 60 minutes later. So it just turns off while you're sleeping and you turn it back on in the morning. And then we have remote care, which is our telehealth platform called Neurosphere Virtual Clinic, which allows us to actually connect to you through your phone like a FaceTime visit. And it works as a telehealth visit. And we can also, us as the doctor, adjust the settings on your DBS remotely. Super cool. Okay, let me show you what that virtual clinic looks like. This is actually pretty cool. So on your end as the patient, you click remote care on and you say, yes, I want to connect to my doc. And then you connect to me. I show up on your telehealth visit, and on my screen, my iPad, you show up in the corner. We perform a telehealth visit like we would do with any telehealth visit. But I can also adjust all the settings on your DBS remotely. Really, really neat stuff. Okay, you remember Keith from the beginning? The guy who'd worked in orthopedics and had to quit and felt like he was shaking doing everything? Well, Keith mentioned it. He got DBS. Let's hear what he has to say about how that went. Let's see. Take it over,
I
Keith.
think there's no way anyone is going to be drilling a hole in my head and putting an electrode in there. Well, I got it done. And it's the best thing I ever did. That part, the part I was most scared to death with, the hole drilling, didn't even feel it. It was nothing like I was thinking it to be. The procedure itself was easy. The surgeon that I went to, he basically gave me some options, and the Abbott DBS system is the one that we thought was going to work the best for me. After I had my procedure, they brought me up to the ICU, and I picked up a glass of water, and it just went like this, and I'm just going, oh, it's gone. It's absolutely gone. And I'm just thinking, why the heck did I wait so long? My surgery was November 30th. I was out 3 weeks and went back to work 100% normal. Since I had the procedure done, I don't take any medication. It's mind-blowing. And this DBS system absolutely did what I wanted it to do. I can write, I can eat, I can drink, I can do whatever I want. You're not self-conscious anymore. You go in for 2 program settings, 4 or 5 weeks after my surgery date. Met with a nurse practitioner, and she went through the whole programming cycle. And she set a range from 1.50 being the minimum up to 2.0. And I can actually control the device with an iPod. It prompts you on exactly what you have to do. And then when you're done with how you want it set, you just turn it off, put the iPod in your pocket, and away you go. My plans for the future are to get my other side done, to get the same results that I had with my right side, and in terms of my work to get back in the operating room. I think what I would tell people if they were considering to have this done is, I was just like you. I know you're anxious, scared. You just wake up one morning and say, let's go, I gotta get it done. You'll know when to get it done. I'd recommend this to anybody. Bring them in. I'll tell them what it's like. It's amazing how it changed my life. It's a miracle. Definitely 100% worth it.
That's cool. Well, and I can tell you, we do DBS a lot. We hear that a lot. It works. So what do you do? Well, you need a movement doc, a movement trained neurologist to be part of your team. You can use the scan me on the left, find one of those docs near you. You can also connect with other patients who've had DBS. There are a whole lot of people out there that would love to tell you about their experience. There's also the website lifewithdbs.com that's got all kinds of good information on it. And with that, I do want to say thank you to everybody and get this off the screen and then open the floor to questions or some way that I can help with everybody's understanding of all of this stuff.
Great. Well, there have been some questions peppered in even in the beginning of your slide. So I'll start from the beginning. Someone mentioned they were diagnosed with ET plus,
Yes.
and is DBS an option for ET plus?
Yes. So there is no such thing as ET plus. Don't tell your doctor that. Um, so about 20 years ago, go back to when I don't know, just Destiny's Child was just coming out. I don't know, that might have been 90s. What was like early 2000s? I gotta get my trivia back better. Spiked blonde hair. It could be fun. Either way, about 20 years ago, we used to think that there were two big categories of essential tremor. That there was essential tremor that was just tremor, and then there was essential tremor plus, which meant that it was tremor plus other stuff too. So balance and gait and voice were the things we would include in that category. Well, there were a number of studies that came out, and over time we came to realize that there is no such thing as two different categories. They're all the same thing. So everybody with essential tremor tends to have a little bit of balance issues and maybe a little bit of vocal tremor. And so there really isn't an essential tremor plus anymore. Don't tell your doctor that. Let them feel like they got it right by calling you ET plus. That's fine. The important thing to remember is that there's no difference in treatment between essential tremor and essential tremor plus because they're the same condition. So DBS works great. The medications give us what they give.
And I'll add, you mentioned seeing a movement disorder specialist instead of a primary care or even a general neurologist. And it's these nuances where physicians like Dr. Falconer go through additional training or up to date on the latest research. So really urge everyone to find a movement disorder specialist. And I love that one of those Abbott resources is to help you find an MDS near you. Um,
Absolutely.
yes. So next up, someone wondered if ET is genetic. Is there a
Mhm.
genetic test?
No, there's no test for it. I wish there was. Um, yeah, I see the same question, wondering if their kids or grandkids are going to get it. There's no way to tell. It's not something that has to be passed on, but it can be. Remember, 60% of the time it does. But then there are families where you have five kids and only two of them have essential tremor. That's the magic of genetics.
Okay. Okay, someone asked about internal tremor, and I've heard a lot of people with movement disorders reference this, but
Yes.
uh, so I wonder if you could maybe
Yeah.
explain what
Yeah,
it is.
it's common in Parkinson's too. So internal tremor is a normal phenomenon for many. People with anxiety disorders feel like they shake. But it's very common in Parkinson's and essential tremor. So internal tremor is just a reflection on how much your body senses and tells you that tremor is there. So everybody with a tremor condition has some very minute shaking in their muscles. Everybody does. But only some people with that condition does the brain recognize it and tell you, ooh, you're shaking. The corollary I go with is growing pains. I mean, we all remember either being kids or having kids, and growing pains was a thing, right? I have a 7 and 10-year-old, and yeah, they're like, oh my God, my legs are going to fall off. I feel like they're going to break because they hurt because they get really bad growing pains. My buddy Will, my oldest 10, he has a friend down the street named Maddox who swears he never gets growing pains. Well, this kid's mom is an endocrinologist, and she, at one point, my Will came up and was like, "Oh man, my ankles are really hurting from growing pains." And the buddy Maddox comes up and is like, "Oh, Will, that's because whatever, I don't get those." His mom told him, "Well, no, everybody gets growing pains, but for some people, their body says that it's a problem, and some people's body tunes them out." And I said, "Huh, well, that's the exact same thing as internal tremors. Everybody has internal tremors. I have internal tremors. And if you have Parkinson's or essential tremor, on a microscopic level, your muscles are tremoring. And only certain people's brains tune into it and say it's a problem. and other people tune it out.
That's a great explanation.
Growing pains.
Yeah. So, okay, if you have a low normal heart rate at 50,
Mhm.
52 and on gabapentin, is DBS an option?
Yes, DBS is an option. I see the question. The gabapentin is a tough one. I've had one person in 10 years say it helps, but then again, if it helps for you, you can be number two, and that's awesome. And I do want to call out the person who said they used a large coffee mug so they don't spill. Absolutely. A lot of people do that. I was just really impressed because that lady's mug seemed like especially huge. And it also sounded like it was made of like, like iron, right? And so I was just, she could like whack somebody with that thing if she needed to. I was impressed by her mug. It
Yes.
also said Queen on it, which I didn't point out too.
Yes. Um, if you have a pacemaker, which I assume heart
Mhm.
pacemaker, can you have lots of equipment in there?
Yes, you can have both. In fact, most surgeons put the DBS on the right side to leave room on the left if you need a pacemaker.
Okay. And I think there was a slide about the software updates, but someone asked,
Hmm.
did the Abbott system get better over the years?
Yeah, it's all built on an Apple platform. So not the technology in the device, but your programmer is an iPhone, it's an iPad. Apple's extremely good at pushing updates. So yeah, you can update the device by simply connecting to it with your programmer. Very easy to do.
Which is a segue to the next one. So no
Yeah,
Android,
I
just
don't
Apple.
think so. That's a question for the Abbott team. I don't think it's Android compatible. Um, I don't think so.
Okay.
But the company will give you your own iPod that you can use to connect to it. Brad, is
So
it
I,
is it Android?
I can't actually answer this question. So we actually just updated our patient hardware. So a lot of the feedback that we got was actually that some patients don't prefer an iPhone because some people prefer an Android, to your point, and some people think that's a little more simple. So going forward, we've actually done two things. We're now providing patients with a new Android phone when they get their implant, and we've actually whitelisted all Apple iPhones now. So the second that a new phone comes onto the market and the second that a new software update goes live, it's immediately compatible with your own personal iPhone if you prefer to use your own device. So there's no longer any needing to wait for any sort of compatibility. It'll happen live that first day that it goes on the market.
Great.
That was the correct answer. Fantastic.
Yes. And I'll
Thank you,
squeeze in
Brad.
the last one. Can you have DBS for both ET and Parkinson's tremor?
Yeah, you can. We talked to your doctor about that. It is a more complicated decision as to how, because that would be two different targets in the same side of the brain. We have a number of patients who we try to do things to ameliorate both. Talk to your movement specialist. That is a very unique circumstance that requires a very well-trained and informed doctor to navigate.
Hmm, very good. Well, we didn't stump you, Dr. Faulkner.
I try. I'm sorry. I
Still,
could say I don't know. Could be fun.
yes, but thank you for a great
Of course.
presentation. The videos and the stimulation on and off. I've never seen that before. That
It's pretty
really,
cool, right?
yeah, really powerful.
Well,
And
and
thank
it's not
you.
even cinema. It's real. Like that's what we do in clinic, and it never gets old to watch that tremor stop.
I bet. And so helpful for those of us who aren't in clinic all day to be able to see it. So, thank you to all who tuned in and spent some time with us. And as we mentioned, this recording will go up on our website and our YouTube. Give us a couple days to get it. And if you think of any other questions, email us. But really appreciate Dr. Faulkner and thank you to Abbott for putting the deck and bringing this together. And just want to wish everyone a great afternoon. And until next time, stay tuned for your emails for our next webinars. We hope to see you soon. Bye, everyone.